Acute rheumatic fever is a delayed, multi-system inflammatory disease. It typically manifests 2 to 5 weeks after a specific bacterial pharyngitis infection. Over time, the mitral valve thickens and calcifies. These leaflets fuse together, eventually failing to close completely against the high-pressure flow of blood. In developing nations, an annual incidence of 282 per 100,000 people makes this the leading cause of acquired heart disease for children and young adults. Physicians have long used a specific axiom to describe the disease's selective destruction. It licks the joints, but bites the heart. ARF is an immune-mediated cascade. The damage results from the host's own defensive response attacking healthy tissue rather than a direct bacterial invasion of the heart. The process begins with an infection by rheumatogenic strains of group A beta-hemolytic streptococci, specifically types like 1, 3, 5, or 6. The group A streptococcus cell wall is defined by protruding M proteins. These structures allow the bacteria to resist phagocytosis by the host's immune cells. During a latent period of 2 to 4 weeks, the host's B cells generate specialized antibodies designed to neutralize these M proteins by mapping their exact molecular geometry. This initiates antigenic mimicry. The molecular geometry of the bacterial M protein is structurally homologous to the host's own tissues, specifically where bacterial carbohydrates align with mammalian hyaluronic acid. These circulating antibodies cross-react, locking onto healthy cells in the myocardium, basal ganglia, and joint synovium to trigger a wave of inflammation. By the time physical symptoms appear, the original bacteria have usually been cleared. The multi-system destruction is a direct result of this molecular mistaken identity. This immune response manifests first through migratory polyarthritis, the most common major clinical symptom of the disease. This arthritis targets large joints like the knees, ankles, and elbows. They become hot, red, and swollen for 1 to 3 days before the pain migrates to a different limb. As shown in this anatomical diagram, the inflammatory response specifically targets the synovium and the joint capsule. These joint symptoms respond rapidly to salicylates like aspirin. Historically, the severity of this arthritis often shares an inverse relationship with the degree of cardiac damage. The disease licks the joints because the inflammation, while acutely painful, eventually resolves without causing permanent structural changes to the joint. Recovery in the joints contrasts with the permanent damage of carditis, which develops in 50 to 60% of patients. Rheumatic carditis is a pancarditis. The immune system simultaneously inflames the myocardium, the pericardium, and the endocardium. Auscultation, as shown in this clinical setting, is used to detect valvulitis. This universal finding presents as an apical pansystolic murmur radiating to the axilla. Antibodies targeting the basal ganglia result in Sydenham chorea. This neurological manifestation causes emotional instability and uncontrollable, uncoordinated movements. Chorea is identified by specific clinical signs: facial grimacing, a milkmaid's grip, and a Wormian darting movement of the tongue on protrusion. Rarer markers include erythema marginatum, serpiginous lesions with pale centers, and firm subcutaneous nodules found along the extensor surfaces of tendons. While the neurological and joint symptoms eventually fade, the silent bite of pancarditis leaves behind permanent tissue damage, leading to chronic heart failure. Because ARF lacks a single definitive test, clinicians use a risk-stratified matrix to prevent misdiagnosis, the revised 2015 T. Duckett-Jones criteria. The Jones criteria, shown in this table, provide a mnemonic for the 5 major clinical manifestations used to build a diagnosis. No diagnosis is valid without evidence of a recent group A strep infection, such as a positive culture or an elevated ASO titer above 333 Tods. The 2015 revision separates patients into 2 distinct pathways, based on whether they reside in a low-risk or a moderate to high-risk population. In high-risk populations, diagnostic thresholds are lowered. The required peak ESR drops from 60 to 30 millimeters per hour, and the fever requirement decreases to 38.0 degrees Celsius. The definition of a major criterion also shifts. For high-risk groups, mere monoarthritis is sufficient for a diagnosis, whereas low-risk groups require strictly polyarthritis. Reaching the threshold of 2 major criteria, or 1 major and 2 minors, triggers immediate medical intervention. Medical management is split between suppressing the current inflammatory event and preventing future recurrence. High-dose aspirin is used to treat arthritis, while corticosteroids like prednisolone are reserved for cases of severe cardiomegaly and heart failure. Once the immune system has mapped host tissue, any subsequent strep infection will trigger a faster, more aggressive autoimmune attack on the heart valves. Secondary prevention, supported by large-scale penicillin production as seen here, is required to eradicate strep before the immune system can react. Prophylaxis protocols require regular penicillin injections until age 18, extending to age 40 or even for life if the heart valves are involved. Managing the consequences of mistaken identity depends on strict clinical vigilance and decades of prophylactic discipline.